एक minute. I'll just change it. 1 minute. I'll just.
Yes. हाँ सर का हो गया है शायद.
हो गया सर.
Yes, done.
It's done.
We can go ahead live. We can go live.
Manish ji, we go live.
Okay. Okay. Good evening, everyone. This is the first webinar of Dermatoscopy Society of India, that is called as Dysi, which is recently formed. Earlier, it was Academy of Dermoscopy, and this particular society was formed on 27th of May 2020 during Corona on online basis. So the motto of this society was to spread and disseminate knowledge of dermoscopy across India, across world. So we had different office bearers in the past. Now we have a young, energetic team consisting of Dr. Samipa Madam, Dr. Payal Madam, Dr. Sahu Madam, Dr. Saumil, Dr. Vinay K, Dr. Sishira, and Dr. Yasmin Madam. So these are all office bearers, and myself is the president. Dr. Saumil Kar is the vice president. So this society is to disseminate knowledge of dermoscopy across India, and we have many projects in pipeline, including including Instagram page, then AI in dermoscopy, and many books, and also newsletter as well as journal. We are trying to bring it out, and website is being created, and we will open for membership also very soon. So this is a basic webinar in the as the celebration of occasion of origin of this particular society on 2020, that is May 27th. So let us learn and discuss about basics as well as a few interesting cases of dermoscopy in this webinar. Over to you, Dr. Saumil.
Good evening, all.
Saumil, you should unmute. Yes.
Good evening, all. Thank you for the welcome, sir, to all of us. We have an exciting and insightful set of sessions that are lined up today, and I encourage everyone to engage actively and make this most out of this academic event. Let's begin our journey with the basics. Our first session is titled Introduction to the Dermoscope. And to take us through this foundational topic, we have Priyadarshini ma'am. Priyadarshini ma'am is a consultant in the Department of Telemedicine, PGI MER, Chandigarh. She was ex-associate professor in BD Sharma PGIMS Rohtak, and she is member of SIG Dermoscopy till now from 2022, and still currently she is the member, and also a member of SIG member of pigment diseases. Ma'am has more than 50 publications, more than 30 presentations, and her field of interest are dermoscopy, pigment disorders, and dermatosurgery. Over to you, ma'am.
Very good evening. So I'm starting with the first lecture. So without delay, we will go to the introduction of dermoscope. In this, I will discuss what is a dermoscope and what are the components and how we operate it. Can everybody see this? Okay. What is a dermoscope? Dermoscope is also known as dermatoscope, skin surface microscopy, epiluminescence microscopy. It's a simple, non-invasive method which works on the principle of transillumination to examine the skin structures in the epidermis, dermoepidermal junction, papillary dermis, which are usually not visible to the naked eyes. So what are the components? That is important to know. There is an illumination system is there. There is an achromatic lens is there. There's a contact plate and there is a power supply. So in this, there is a high quality achromic lens which provide a magnification of about 10x to 20x is provided. However, this magnification varies. In handheld, it is 10x to 20x. In USB dermoscope, it is 20 to 500x. In high-end video dermoscope, it is up to 1000x also. There is quality of image. In case of a handheld dermoscope, there is a better quality of images that although the magnification is low, in USB video dermoscope, there is higher magnification, but the quality of image is slightly compromised. In high-end video dermoscope, there is very high quality of image and higher magnification also. So higher magnification doesn't mean there is a better image. However, the size of lens, if it is larger, then it is useful to cover a larger area. In case of halogen, there is LED light emitting diodes in our DL4 and DL5. There is LED are placed, and previously there were halogen lamp. These LED lamp were oriented at 20-degree angle and have polarized on both the non-polarized sources. There is a multi-spectral dermoscope is also there technique in which it utilizes light as multiple specific wavelengths. Suppose it is a blue light, then it is similar to UV, and if it is a green light, it is important for mucoscopy of NFC, and if it is in yellow, then there is in spikes of onychomycosis in the thick nails we can see. So blue is for superficial one, yellow is for the deeper one. There is better visualization as there is penetration of skin by light in proportion to the wavelength of the light is there. Pigment boost is also there in the DL4 devices, DL4 and DL5 derm light is there. Then there is a new one is coming with DL5, that the UV fluorescent dermoscope, where the UV light source is used to evoke the fluorescence by the chromophores. They emit actually the photons, which have a longer wavelength that appear as a fluorescent visible light. A phenomenon known as the Stroke's effect is used in this. There is also the contact plate, that in case of contact plate, there is glass plate with Ri similar to the stratum corneum is there. There is multi-coated, it is a multi-coated silicon glass. It may be graduated where the scales are inscribed. It is used to measure the size of the lesion. It can be removed. As you can see in this image, there is a spacer is also there. So in case of a handheld dermoscope, it is powered by batteries. There is rechargeable lithium-ion batteries are there or alkyl battery. Some dermoscope provided with compatible charging dock are also there. Video dermoscopes are usually provided with the USB cables. The software and AI analysis are also there in some dermoscope. The mobile apps are applicable to digitally store these images. There are what we use is there is a mobile app in case of DL4 where we can store the images. That the high-end video dermoscope come with software with inbuilt AI, artificial intelligence analysis. USB video dermoscope have dedicated software to help with the measurement of structures and calibrated properties. So now the principle of dermoscopy in case of this, when the light passes through a medium, suppose this is a glass medium, there will be the light will get refracted, scattered, absorbed, or the reflected back is there. So skin, the refractive index is 1.5, the glass is 1.52, and the air is 1. So whenever an illumination system is there, when there is an incident light, the light get reflected back from the surface because there is a difference in the refractive index. In case of skin, it is 1.55 as compared to air, which is 1. Whereas when we use an interface medium, the refractive index increases. So it matches optically and minimizes the glare so that more light can penetrate the epidermis and the dermal. In case of dermoscope, we works on the principle of cross polarization. There are two filters which are held at 90 degrees. The source light initially is polarized with the first filter, then the reflected light from the skin is blocked by the second filter, and the non-polarized lights can pass through the polarizing second filter. So there is an parallel polarization where the polarized filter on the dermoscope are aligned in the same in the same direction. So visually extremely superficial structure can, especially keratinization, is visible. So same lesion in case of DL5, the same lesions can be assessed at the different depth with parallel polarization. Okay, so now the linkage fluid which we use, we can use normal saline or water, alcohol disinfectant such as 70% isopropyl alcohol and 90% isopropyl alcohol can be used in case of infective conditions that the least number of air bubbles are there. We can use ultrasound jelly or electrode jelly, which can be the mucosal, nail bed, genitalia or the eyelid. Immersion oil, however, in earlier we use it, but due to the carcinogenic and phytogenic properties has been discontinued. Liquid paraffin can be used, but it has an highest air inclusion. So this is a comparison where I have compared the non-polarized with the polarized dermoscopy. In case of non-polarized, that the direct contact with the skin is required. In case of polarized, it is not required. In case of interface fluid, that is required in case of non-polarized. In case of polarized, it is not required. So the principle here, there is a glass plate interface fluid skin surface which set up to decrease the glare. In case of polarized, there is a cross polarization to decrease the glare. The structures which are on the surface structures are better visual. In case of polarized, the deeper structures are visible. So in case of infective mucosa, we can use usually the non-contact. In case of contact, we can have the ice cap, cling film, cover of surface material. So I usually use this the screen cards. This is, I cut it into what I do. I cut it into 4. So this is a smaller size. Now I used to attach. I remove the surface. I remove that the 2, and now this is the sticky end which I'm showing, and it can be easily sticked to the dermoscope. So this is the way I attach it to the dermoscope, so it get easily, and after using you can remove it and you can change it for every patient also. So how to choose a dermoscope? It is between the handheld dermoscope or it is a video dermoscope. If it is a handheld dermoscope, then it is 10x to 50x magnification. You have to attach it to the smartphone, then only it is 50x. Then the video dermoscope, it can be up to 500x. In case of handheld, that the whole contact plate comes in contact. So removable contact plate, or you have to attach some barrier between that. In case of video, only the rims comes in contact. So in case of handheld, that is a direct visualization. In case of video, there is an external screen is required. So the advantage with the handheld, that it is a portable, it can be used faster screening, busy OPD, government setup, beginners can use it. However, it is slightly costlier. In case of video dermoscope, viewing by the patient is possible as you can attach it to the laptop. That the single setup, private setup, research setup, you can use this video dermoscope. So these are the handheld dermoscope which are available. I have these two. This is the first one is the DL5, where I have removed the cover plate, in which you can see that cover plate can be removed easily. This is the universal attachment. These type of 2 universal attachment are available. So this is a video dermoscope where you can attach it to the phone or your laptop also. So this is one of the high-end dermoscope. This have the higher magnification, and this advantage that it's a highly stable, precision, very good quality of images, suitable for advanced diagnostic and research purpose. However, the disadvantage that it is very costly, bulky, and not portable. So I just want to tell you how to do photography in case of dermoscopy. You should focus the image. If the contact plate is not extended properly, the image will be blur and you will see a black hole in between that. So you have to focus that image with the help of the contact plate. You can increase the distance between the contact plate and lens, and you can bring that to your 0 so that it get focused very nicely. You can see the image also. Then use a camera or phone with an adapter, magnetic adapter. Easily simplify the alignment. Liquid interface application, contact fluid to minimize the vessel and vessel compression, or always use fresh contact fluid to avoid the bubbles. Adjust the camera zoom. Zoom is to minimize the black borders and ensure the lesion is fully visible. Include measuring scale for reference. Take multiple shots and use the clearest image, and focus and clarity. Tap the lesion or press the shutter button halfway to focus before capturing the images. So there are some tips. Keep the scope always charged. Explain the procedure or demonstrate on yourself or the patient before performing the dermoscope. Use both the polarized and the non-polarized mode. Always take clinical pictures with dermoscopic pictures to help in correlating. Maintain a register and regular transfer the captured image to your laptop so that your phone will not get packed up. Part preparation is important for better visualization of the lesion. So limitation, adequate training and expertise is very important. Instruments is relatively expensive. Dermoscope images can vary with the type of dermoscope used, camera and the phone being used, application of pressure, contact and a non-contact method. So thank you. I hope by this I've explained all the things.
Thank you, Priyadarshini ma'am. That was really a very comprehensive introduction and a perfect start for and set the stage for what's to come. Our next session, we will understand the core principles of the dermoscopy. Please join me to welcome Balachandra Ankat sir. Sir needs no introduction. Sir is professor and head at S. Nijlangappa Medical College, Bagalkot. Sir has more than 136 dermoscopy articles, has edited 3 dermoscopy books, and the lectures he has taken on dermoscopy are 127. Definitely tells sir's areas of interest is dermoscopy in clinical practice. The stage is yours, sir.
Thank you, Samuel. Am I audible?
Yes, sir.
Okay. So fundamentals of dermoscopy. It's the basic science of dermoscopy. It's like learning a new thing. As we enter as a dermatology resident to dermatology department, we learn many things, including basics, papules and macules like that. One has to learn what is dermoscope and what is the process of dermoscopy. And Priyadarshini madam has very nicely told about the scope and part of the scope and how to use it. And I will directly go into the basic science of dermoscope.
So please, can you switch to slideshow?
Okay. So what do you think this is? And this is obviously a parrot. Why it is called as parrot? Because 1 minute. Yeah, it has got a black eye and green wings and a red color beak. So hence it is a parrot. So we know this is since childhood. It is being trained like this. This thing means this is parrot. So there is a feature that is color and also there is a pattern. So to learn dermoscopy, one has to see the feature, see the color and pattern in which they are arranged. So then diagnosis is very easy. So what is this? This is psoriasis. We know that this is a erythematous plaque with silvery white scale. So this is psoriasis. So very easy to diagnose, but when lesion comes like this, hyperpigmented lesion, upon that few papules are there, and again hyperpigmented lesion and one more prominent plaque is there, so there comes a difficulty. So we need to exercise our lab investigations, invasive, non-invasive. So in particular this case, so upper part of the lesion, that is flat hyperpigmented patch, it shows dotted vessels with pigmentation with few scales, whereas this below picture shows pinkish background, scales are more, as well as dotted vessels are there. That means one is healed psoriasis, below one is active psoriatic lesion. This is what dermoscopy tells us. And the second example, so upper part is Bowen's disease, lower part is tinea. So there is a development of, it's a coincidental finding of Bowen's disease upon the tinea infection. So this is the beauty of dermoscope. So one learns the future patterns and can analyze and diagnosis can be very easy. How to use it? So madam has already told. So just to how to attach the adapter. This is a quick this thing. It's not 1 minute. Is it visible?
Yes, sir.
Yeah. this is a dermoscope, and these are the power button, and there are two buttons are there, polarized and non-polarized, and there can be adjustment of brightness also. As Madam told, it should be in the midway. Illuco doesn't have scale, but Dermalite has got scale, so to 0 one should bring it. This is a universal adapter. This is a smartphone. So universal adapter means camera can be anywhere from the center to the corner, so that can be adjustable. This is how it's being adjusted. And it has to be attached. Both universal adapter as well as dermoscope has got magnetic ring. They attach very easily. So this is second this thing. This is non-polarized uh, dermoscopy. So one thing I would like to tell here is we are using green or blue color this thing ultrasound gel, but better to use white color, that is ECG gel, for the clarity. So this is polarized non-contact. It takes little practice to become handy. So you have to keep your finger as a support and examine the lesion. How to take photographs, again, Madam has told in detail. This is ready. So adjust the dial and camera. So if a dial is very near to the contact lens, so that lesion will be blurred. So blurred image or blanching over the center. Black halo. So if it is very too far from the contact lens, you can see here. So we can have this black halo, a ring. So this is also not correct method. So correct method is, so keep the scope, adjust the dial, then zoom it, then click the image. So this is how we should take photographs. So after we have dermoscope as well as how to know how to take the images, so what to do now? So we need to learn language of dermoscopy. So there are primary structures and are called as basic elements. So these are the basic elements. So lines, these are all solid objects with length exceedingly more than the width. So lines can be pigmented, non-pigmented, and clots. Clots are solid objects with definite shape and size. They vary in color. And pseudopods is nothing but line with a bulbous edge. Dots are pinpoint structures which cannot be measured. It's like full stop point. Circle, actually it's being described in the pigmented lesion where periphery is pigmented with the central clearance, but these circles can be seen in non-pigmented lesions as well. As one more important thing is structural area. Areas large enough to form patterns but without any discernible elements in them. So recently it has been described as there are two types of structural areas. One is diffuse, next one is focal. But focal structural area should not be confused with the cloud or globule, which will be discussed later. So lines can be arranged in reticular, which are in honeycomb pattern, parallel, especially seen in palms and soles. Branched, again, palms and soles, there is a branching of pigment lines from furrows to ridges also. So radial lines at the periphery. So pseudopods, I told you that lines with a bulbous end, you can see at the periphery there are bulbous end, and circles here, pigmented structures at the periphery with center clearance. Here it is, now it's clear. So clots and dots, they are dots are very pinpointed structures, whereas clots, they are here, they are bluish and blackish, and they vary in size and shape also. So structural area diffuse, there is nothing except white structureless area in this lesion, And here you can see a structure is there, and we have a pale pink color and a dark pink color in the center. So this dark pink color can be called as focal structureless area without any dots or clots. So this is for just quick this thing, quiz like thing. So what are these? These are clots, these are red dots, these are peripheral brown lines. So coming to vascular patterns, we have dotted clots, linear, looped, comma or curved, helical, twisted, and this is serpiginous. So examples, this is dotted, you can see pinpoint dots. So bigger dotted lesions are called as globular vessels or clots, red clots. So these are linear vessels. Diameter can vary, but they are called as linear vessels. Coiled, they are twisted, they are curved upon themselves. These are also called as glomerular vessels or coiled vessels, twisted vessels also. So these are looped vessels. Actually, linear vessels, two linear vessels, at the end they are looped. So linear vessels, linear looped also, so it's called as linear looped vessels also. Serpentine, so that linear vessels with many twist curves, it's called as serpentine, just like snake. And curved vessels, here whole vessel is curved, not like looped vessel. Looped vessel is linear with at the margin they are curved. Here entire vessel is curved. Polymorphous vessel, more than two types vessels present means it's polymorphous. Here there are linear, branching, dotted, curved vessels are there. So what to do after we know these things, dots, clots, and basic structures, vascular structures? We have information, we need to join them. Join the dots to get a correct diagnosis. So one more practical point is mark the specific area for taking biopsy. See, this is a clinical image of dermatosis, and we have marked here, and this marked image can be scoped, and we can see these multiple dotted vessels with white halo with scale, and vessels are in the cluster form. So always correlate dermoscopic patterns with histopathology. Why to mark the area before taking biopsy means we can have a maximum yield of histopathological report. Otherwise, sometimes we may get optimum or appropriate features in histopathology. So histopathology correlation is very important here. This structure, this is bluish in color, it corresponds to the acanthosis, whereas brown, it corresponds to the melanin present in the basal layer, whereas red clots vessels, they are dilated vessels, whereas blue structures are indicating here is melanophosis. So the art of dermatological diagnosis is a complex process that requires many skills, including clinical history, clinical examination. Dermoscopy should not be practiced in isolation. Single dermoscopic lesion, most of times it's difficult to diagnose, but there are few lesions, say for example tumorous conditions, they can be diagnosed with solely on dermoscopic examination. Hence clinical diagnosis is a summation of clinical history, clinical examination, dermoscopic examination, and histopathological examination also. So these are the few books I would like to recommend you for beginning of the dermoscopic study. So few Indian authors also there. Subrata Malkar sir, Trichoscopy, Dermoscopy, and Jonathan Bowling is a good book, which is Diagnostic Dermoscopy Illustrated Guide, and Lydia Rudnick has written Atlas of Trichoscopy, and we have our books also, Dermoscopy, Histopathological Correlation, IDVL Atlas of Dermoscopy, Clinical and Dermoscopic Atlas of Non-Neoplastic Dermatosis. It compares both skin of color as well as skin type 1, 2, 3. Thank you.
Thank you, sir, for simplifying the fundamentals so effectively. and making it even more informative and thought-provoking. Now we move on to the application of the dermoscopy in pigmentary disorders. I am pleased to invite Samipa Mukherjee ma'am, who will enlighten us on dermoscopy of hyperpigmentary disorder. Samipa Mukherjee ma'am is Chief Dermatologist and Director at Dr. Samipa's Skin, Hair, Nail Clinic, Bangalore. She's a consultant pediatric dermatologist at Cloud9 Hospitals, Bangalore. Ma'am has numerous honors and achievements, publications, more than 70, presentations, more than 130, and she has a wide area of interest. That is pediatric dermatology, dermoscopy, atopic dermatitis, trichology, and clinical dermatology. Over to you, ma'am.
Thank you so much, Somil. So I am here to discuss with all of you the disorders of hyperpigmentation. Now, probably this is going to be the toughest topic for the day because personally for me, I find dermoscopy of hyperpigmentary disorders to be one of the toughest. And this was the only thing in dermoscopy which I took a very long time to understand and to learn. Even now, we are still learning because as you will see, I will share cases where, we have had confusions and then through discussions, we have learned it further. Thank you so much, Ankit sir and Dr. Priyadarshini, because you have set the ground for me to go ahead with this particular topic. So why do we require dermoscopy for hyperpigmentary conditions? So you will probably require to use your scope in patients where there is a history of chronic usage of hydroquinone, if you're getting it in the history. Facial hyperpigmentation, where they are not adequately responding to treatment. Facial hyperpigmentation, which has undergone a treatment option and then it has either relapsed following up initial improvement or absolutely not budged. If you see that there are any textural changes in the skin on palpation and you are unsure if there is a coexisting dermatosis along with something else going on over there. And of course, if visibly when you stretch the skin and you're able to see any telangiectasias and you need to convince the patient with regards to the diagnosis that you are giving. Now, the parameters that we are generally going to assess in pigmentary conditions, these are about 6 of them. So you will always look for the background color. You will see the pigment pattern, how it is. You will look for any vessels or vascular involvement if there is. If there is any scales present and what is the nature of the scale, also what is the location of the scale. What is happening with the follicles? Now, follicles, there might not be too many changes. You will see in few conditions, there are few changes. However, most of it, there won't be changes, but it's important for us to know the position of the follicle because you will be able to figure out if the pigment is being deposited inside it, around it, in what pattern it is being deposited, and that also helps in your diagnosis. Then comes in your special features, like if you are seeing certain characteristic features, which I will show you again, you will be able to lead to the diagnosis. Okay. Now, are you able to see the screen? Because I just kind of lost my screen. Somil, is the screen visible?
We can see the parameters to assess pigmentary conditions.
Okay, but I am able to see your screen over here. Why is that so?
My screen?
Yeah. Okay, 1 second.
I'm not.
I mean, I'm not able to see my screen, so I don't know what is going on the screen. 1 second. I will just stop sharing and I will reshare it. Now, are we able to see the screen?
Yes, ma'am. First page of your PowerPoint is there.
Perfect. All right. So coming to the choice of equipment, I think there is no discussion required on this. Polarized light non-contact dermoscope is what is preferred, and that's why it will require a bit of your practice so as to understand as to how this is going to work very well in your clinical practice. And the disorders that we are going to discuss today are not all your disorders of hyperpigmentation. We are going to deal with the commonest 6 that we encounter. So lichen planus pigmentosis, how do you differentiate it from erythema dyschromicum perstans? What are the various patterns that you see in lichen planus pigmentosis? Melasma, what are the patterns that you see in melasma? How do you differentiate it from exogenous ochronosis? Frictional melanosis, and how do you differentiate it from seborrheic melanosis or even seborrheic melanosis per se? How are you going to see and treat it in your clinical practice? So coming to the first one, now lichen planus pigmentosis, all of these pigmentary disorders, if you're going to remember those 6 parameters that we have looked into, if you go by that, you should be able to come to a diagnosis. First thing when we look at is you can see that there is a brownish background, but there is also a bluish gray background in certain focal areas. You do see globules and dots which are present, and the globules and dots vary in color ranging from brown to blue-gray. Also, what is very characteristic over here is see that the follicular and the eccrine openings are all spared, and the granular deposition or the globular and dots deposits which is there, which is all concentrated around the perieccrine and perifollicular area. Another image to show you that there is a diffuse involvement over here. It is more brownish in color. We don't really see grayish. Here you are seeing a slight reddish or erythematous or pinkish background color. This is probably because of inflammation, and it is very early in stage it has presented, that's why. And you can see these brown dots and globules, very few bluish gray globules and dots which are present around the follicular and in the perieccrine zone again. Another pattern that we see in lichen planus pigmentosus is the dotted pattern, where you see that the dots are scattered. But what's important to note over here is see that it is pairing all the skin creases over here. Okay, so this is another pattern you see in lichen planus pigmentosus. Another pattern which we see is a speckled appearance, where we see more of dots which are blue-gray and brownish in color against the background of it being brown. It can be slightly grayish or pinkish in certain areas. And this is again a pattern where you see more of the dots, very few globules. Again, they are scattered in a very diffuse manner. It is not present in a particular arrangement over here. Okay. Also to note is the characteristic of the granules over here. They are pretty prominent. They are visible without you trying to take any efforts to actually see it, right? Another slide, this is from Ankit sir. This is showing that the blue-gray pigment has been deposited around the follicles and around the eccrine glands in actually an arcuate pattern or a C-shaped pattern that you can see. Look at the nature of the granules. They are very coarse, they are bluish gray, and they are stark. They are ready to burst on your face, right? So this is another pattern that you see. Also, the classical hem-like pattern. Now, if you look into this image, you can see the brownish background, you can see the bluish-gray background, you can see the bluish-gray globules as well as dots. You also see the brownish dots, and they are more or less arranged in a hem-like pattern. Hem is nothing but the seams of your clothing where the stitching is done, where it is linear and they are parallelly arranged. Another image showing similar to the hem-like pattern, but again, characteristic is to note the sparing of the creases which happens over here. All right. Moving on to the next disorder, which is erythema dyschromica perstans. Now, see how subtle the differences are. And the differences are subtle because somewhere in line they are connected histopathologically. So in erythema dyschromica perstans, the pigmentation is much deeper. So you see more of bluish gray background as opposed to the brownish background. You are going to see more of bluish gray dots and brown dots as well. But these are not very stark. They are dim and they are just irregularly scattered. They do not really follow a pattern over here. Another image where you are able to see that the globules and dots are bluish gray in color. There is a little bit of erythema which is going on in this zone. You can see the bluish gray background over here. You can see the brownish background over here. Again, look at the nature of the dots and granules. They are not very stark. They are fine. They are dim and they are not as coarse or as intense as you had noted in the lichen planus pigmentosus. So that brings us to a dilemma. This was a case which I recently discussed with Ankit sir because I was also confused. So look at the image to your left. Now here, if you look, the background is more or less brownish and there is a pink background going on. We are not very well able to appreciate the bluish gray background. If we look at the nature of the granules, they are prominent. They are there, but they are not as stark and prominent as you would see in a lichen planus pigmentosus. The color of it is predominantly brown globules and you do have blue-gray globules and dots as well. But when you look closely at it, so I thought this is lichen planus pigmentosus. Sir thought that this is erythema dyschromica perstans. But when we looked closer, we realized that these blue-gray dots and globules are actually arranged in a linear pattern, and we do not see this linear arrangement in EDP. So we diagnose this patient to be lichen planus pigmentosus, right? So the difference between lichen planus pigmentosus and erythema dyschromicum perstans, first thing to understand is in these two conditions, majority are dots and globules. So if you are seeing more of dots and globules under your dermoscope, which is brown or blue-gray in color, you are going to think of these conditions. The color is more brown and less blue-gray in LPP. EDP, it is more blue-gray and less brown. Distribution is very dense in lichen planus pigmentosus, whereas it is irregular in erythema dyschromicum perstans. Location of the granules is generally periacrine and perifollicular in LPP, whereas it is irregular in EDP. The granules are generally coarse, large, and intense in lichen planus pigmentosus, whereas it is smaller and dim when we talk about erythema dyschromicum perstans. The background color, again, it is more of brown with bluish in LPP, but when we say EDP, we see more of bluish gray, pinkish areas as well as brown areas. Okay. Now, moving on to the next condition, which is melasma. So why do we do dermoscopy in melasma? Because you can assess the depth of the pigment. The vascular component, if it is present, you can pick it up very quickly. If there is ochronosis existing in certain areas of the patches, yes, that can be picked up. Telangiectasias can very well be used. You can use this for monitoring your treatment response while you are using medical management or when you are using lasers. Okay. If you are in doubt and you still want to go ahead and do a biopsy, like Sir said, you can go ahead and do a dermoscopic guided biopsy, and this is still going to help, right? So what is the actual pattern that we see generally? The commonest pattern is reticuloglobular pigment pattern. What is this? The pseudo-reticular pattern, which is present on the face, that generally gets accentuated in various shades of brown. So as you can see over here, in the shades of light brown, darker brown, and you can see that the globules which are deposited around those eccrine and the perifollicular areas also. You also can appreciate vascular component very easily under the dermoscope. You also get to see unpatterned patchy pigmentation. Unpatterned patchy pigmentation is where there will be accentuation of the pigment. Again, not in a very, very regular pattern. It is irregular, it is blotchy, it looks like a big brown patch, and there is accentuation of the pseudo-reticular network. You can see granules or dots also in melasma, but the granules and dots are more or less fine and they are irregular. Also, they are only brown in color that we generally land up seeing against a background of accentuated pseudo-reticular pigment network. We also see something called as jelly sign. Now, what is this? So what happens is whenever there is an accentuation of the pseudo-reticular pigment network, you get these concave margins at the periphery of the patch, right? Now, this concave margins of the periphery, jelly sign is a metaphoric term where it resembles that you have spread a jelly on the skin and it is the convex margin of the jelly that has been spread onto the skin. Okay, but I'm sure you can appreciate the accentuation of the pseudo-reticular pigment network. See how beautifully the vascular component becomes visible. So this becomes your guide towards using the particular creams which is required, topical treatment, or even lasers, which when you want to target these kind of melasma. Telangiectasias definitely can be figured out under the dermoscope. And for this, it is very important that you do not put pressure. So that is the reason the non-contact polarized dermoscopy is preferred, because otherwise, if you put pressure, these telangiectasias will definitely not be visible because it will get blanched out and you'll not be able to decipher the vascular component. Perifollicular brown-black pigment may be present in cases of melasma as well. Look at this. Now, this is a situation where the patient had used a topical steroid for the melasma. So you can see so much telangiectasias along the entire field. Also, you can appreciate the hypertrichosis that is visible. Now, these changes reverse when you take the treatment option. So it also helps in counseling the patient, prognosticating and monitoring the therapeutic response in melasma. Coming to ochronosis. Now, ochronosis is a situation where there has been a damage which has already happened. So you are going to get these white focal areas. You're obviously going to be able to see telangiectasias. Now, this shiny white kind of streaking thing that you're seeing is because of the textural change. the skin of of that patient had become paper-like. So even if I was stretching the skin and trying to put my scope, this is in the contact mode. This is the artifact that I was getting because of the stretching of the skin. So in exogenous ochronosis, the points that should be noted are these white patches, which white structureless areas, which actually represents the confetti-like macules you see clinically. You will also be able to see a lot of telangiectasias and these brown curvilinear or worm-like bodies, which can be appreciated again. All right. Again, another image to show you how major the confetti-like macule can be, how much vascular damage can be there, how much of your pigmentary changes, which is part of the melasma, will also be there. The hypertrichosis because of the topical steroid abuse, that also is there. And you can see these curvilinear structures, which has been deposited as well. Differentiating between the two, you will, these are the points that we have already seen. I'm not going to list this out. This is for you to read. We are going to move on to the next topic. So frictional melanosis is the other one. Now, frictional melanosis can present anywhere on the face. So it can be on the beard area, it can be on the chin, or it can be on the forehead or in the temple region. Now, in frictional melanosis, what are you going to see? Look at this square which is present over here. So you can see that there is an accentuated pseudopigment network as opposed to the normal pigment network which you see towards the right-hand corner. There is patchy distribution of brown, gray, and pigmented globules and dots. It's patchy. It is not regular. There is no pattern to it. You can see it here. You can see it here, but you can't see it in other areas. If you look at the follicular openings, they are all patulous. There is some amount of scaling that is present in the perifollicular area, and you also see a lot of broken hair because of the friction per se. Another image to depict the same. So you can see that there is a brown background. It is slightly accentuated as compared to the normal skin. You're also seeing the broken hair which is present. There is some amount of scaling and there is a bit of brown dots and globules which is going on, not in any pattern, but it is patchy. Coming to the next one, which is seborrheic melanosis. Now, seborrheic melanosis generally presents with three patterns. So you can have vascular, pigmentary, mixed pattern. And what is most important to see is the sebaceous excrescences. So in seborrheic melanosis, as you can appreciate over here, you can see the background, which is brownish. This can even be more dark and pigmented in the pigmentary pattern. You can see the blood vessel over here. You can see the sebaceous excrescences, which is present in abundance around the nasal labia, around the nasal ala. Another image which shows that your blood vessels may or may not be in focus. So this is an out of focus blood vessel, which is slight. When the blood vessel is slightly deeper, it generally becomes out of focus. Numerous sebaceous excrescences, which you can see throughout the field. And you can see the background of erythema. Here, you don't really appreciate a lot of pigmentary changes. Okay. So that brings us to the last slide of my presentation. So to simplify, in pigmentary conditions, when you are seeing it, the first thing you're going to look at is for dots and globules, if they are in predominance or not. If they are in predominance, you are going to think of acanthosis nigricans, which I have not discussed. We'll probably discuss in the future series. We are going to think of acquired dermal macular hypermelanosis and exogenous ochronosis. If you are thinking of acquired dermal macular hypermelanosis, you've seen the differences between LPP and EDP. If you do not see predominant dots and globules, you are thinking of the other conditions, which is melasma, seborrheic melanosis, and the frictional melanosis. Okay, so thank you so much. I hope this will help you in your clinical practice to at least start doing the dermoscopy for the pigmentary disorders. And pigmentary disorders does have a learning curve. Okay, thank you.
Thank you, Samipa ma'am. That was a very detailed and practical overview, truly insightful. Continuing on to the focus on hypopigmentary disorders, it's an honor to invite Dr. Vinay Keshavmurthy, sir. Sir is additional professor in PGIMR Chandigarh. Sir has more than 300 publications, 9 chapters authorship, numerous honors and awards. Sir is currently the deputy editor of Pigment International as well as iDodge. And sir's areas of expertise and interest are dermatosurgery, biologicals, dermatoscopy, pigmentary disorders, and systemic dermatology. Over to you, sir.
Thank you, Saumil. Thank you for this wonderful introduction. And thank you for all my previous speakers who have made my job a bit easy. Saumil, can I be heard?
Yes, sir.
Yes. So in this particular webinar, I'll be talking about the dermoscopic approach to hypopigmentary conditions. Mainly, I'll be focusing on vitiligo, and depending on the time we have at hand, I would also discuss other hypopigmentary dermatosis. So, before we go into what is abnormal, it is important that we know what is normal. Only then we would realize what is abnormal. So, I will show the schematics and dermoscopic images of how the normal skin look like. So, this is a beautiful schematics which has been prepared by Dr. Samuel, and you can see that the normal pigmented skin phototype shows this reticulate pigmentary pattern in hexagonal structures, which are nothing but double line. You can see double lines here, and these are two different areas of melanosomes which you see in the retapex. You also see number of white dots. The smaller white dots correspond to eccrine openings, and the larger white dots correspond to follicular opening. And this is what you see on normal skin at 10x magnification. You can see this fine brown lines which are interconnected with each other in a net-like fashion. This is the normal reticular pigmentary network. And these white dots which you are seeing here are all eccrine openings and follicular openings. So this is a common scenario in clinical practice. You get patients with hyperpigmented lesions, and mostly they are children, and the parents are worried if it is vitiligo or not. And it is often not possible to do a histopathological examination in these cases, and dermoscopy really comes in handy in this situation. So the salient dermoscopic features of vitiligo are the diffuse white glow, the broken or absent pigmentary network, reverse pigment network, perifollicular depigmentation, perifollicular repigmentation or pigment retention, leukotrichia, polarization, peripheral white globule, starburst pattern, and we will see each of these in images in the subsequent slides. Diffuse white is the character of all the white glow in other two conditions, which are bivalvism and idiopathic guttate hypermelanosis. And when you see diffuse white glow, only these three differentials come into picture. So it is one of the hallmark dermoscopic feature of vitiligo. And pigment network changes, it can be either broken pigmentary network or complete absent of pigment network. So let us see this in this vitiligo patch. So on the normal skin, you can see this thin white lines which are interconnected with each other, and this is a typical pigment network which you see in type 4 to type 6 skin. And when you come towards the vitiligo skin, you can see that the pigment network is getting broken. So this is the broken pigmentary network. And when you come to the pigmentary patch, hyperpigmentary patch per se, there is loss of pigment network. It is no longer visualized. But what you can see is a diffuse white glow. This is because all the incident light is reflected back from the collagen in the dermis, and this appears as a white glow. And again, the normal pigmentary network, as you come towards the lesion, you can see that there is a broken pigmentary network, and when inside the patch, what you can see is absent or the reverse pigmentary network. This reverse pigmentary network is where there is this pigmented lines in a network-like pattern, and the halo is actually more pigmented than the lines, whereas in the normal skin, the skin between these lines are less pigmented. So the reverse pigment network is again a typical feature of vitiligo, although you can see it in other conditions like melanoma. Perifollicular pigmentary changes are again very typical of vitiligo, and perifollicular depigmentation specifically is associated with active vitiligo patches, and this is a marker of disease activity, whereas perifollicular repigmentation is a good prognostic factor, and it tells that the vitiligo patch is repigmenting and you can continue with the treatment. So this is a patient with rapidly spindling vitiligo, and you can see that there is loss of pigment network, which is typically localized around the hair follicles, and this is called perifollicular depigmentation, and this is definitely a sign of active vitiligo. One more patient, perifollicular depigmentation, and the interfollicular epidermis shows retention of pigment network, and this is typical of spreading vitiligo patches. Whereas perifollicular repigmentation, you can see this pigment network which is reappearing around the hair follicles, whereas the interfollicular epidermis still shows loss of pigment network, and this is a good prognostic sign, and this means that the vitiligo patch is repigmenting, and you can continue with the disease. More photos showing perifollicular repigmentation with loss of pigment network in the interfollicular area, suggesting good prognosis in these patients. As we all know that trichrome lesions in clinically visible trichrome lesions are marker of disease activity, and that holds true even for dermoscopic trichrome lesions. And you can see that the middle part of the lesion shows loss of pigment network. The periphery shows the broken pigmentary network, and whereas you can see the normal pigmentary network here. And this is again a marker of disease activity. Microcorners phenomena are this linearly arranged areas of depigmentation, which is visible only on dermoscopy. It is generally not visible by naked eye examination. And again, this is a marker of disease activity. And satellite lesions are peripheral hypopigmented macules, which you see on dermoscopy. And this should be differentiated by the smaller dots, which are normal eccrine gland openings. They are larger in size compared to the smaller white dots of eccrine gland openings and show loss of pigment network. Again, satellite lesions. And the starburst pattern is a combination of all this, where you have this linear lines extending in a starburst pattern, and this is again typical of spreading vitiligo. The margins can be well defined, as you can see here. This is a marker of stable vitiligo, the peripheral pigmented margins, which are well defined and more pigmented. Whereas ill-defined margin is a marker of spreading disease. Leukotrichia and lesional erythema and telangiectasias are again marker of stable disease. So we did a prospective study and observed sequentially the dermoscopic features of vitiligo, and this is what we found. The pigment network changes, either absent pigment network or reduced pigment network, was associated with active vitiligo. Perifollicular repigmentation was associated with stable vitiligo lesions, depigmentation with active vitiligo again, and satellite lesions and microcorner phenomena is also associated with active vitiligo. So this table kind of summarizes what we discussed till now, and the delegates can actually take a photo of this so that it becomes handy in clinical practice. So we have few minutes left, so we will discuss some of the other common hyperpigmentary conditions. Then nevus depigmentosus is again common in practice, seen in children and often confused with vitiligo. And let us see if dermoscopy actually helps. Yes, it does, and you can see that nevus depigmentosus has a feathery margins, whereas in vitiligo you have a smoother convex margin. And the leukotrichia is generally not seen in nevus depigmentosus. You have pigment retention in nevus depigmentosus, whereas vitiligo has loss of pigment in the hair follicles, and you see leukotrichia. And if you see the pigment pattern here, you are not seeing the diffuse white glow which we see with vitiligo, whereas you can see that the pigment network is partially retained, and this partial retainment of pigment network is typical of nevus depigmentosus and helps you to differentiate between vitiligo and nevus depigmentosus. One more patient, you can see that there are this feathery margins. It is not smooth and convex as in vitiligo, and the pigment network is partially retained within the lesion, and it is not completely lost. Nevus anemicus, again, it is a vascular anomaly and there is no pigmentary abnormality as such. And when you scope, what you can see is that there is loss of vessels within the pale region, and there is a compensatory flare surrounding the pale region. And when you actually do a contact dermatoscope, everything blanches, and there is loss of demarcation between the lesional skin and the surrounding normal skin. And this is typical of nevus anemicus. Idiopathic guttate hypomelanosis, the distinctive dermoscopic features are the diffuse white glow, which we discussed before, and the distinctive margins, which you see in patients of idiopathic guttate. 4 different patterns. It can be amoeboid, petaloid, feathery, or or nebuloid. And we will see photos of all this. In nebuloid, the margins are actually ill-defined and merging with the surrounding skin. In patelloid, you see this leaf-like margins, and in amoeboid, you have the pseudopod-like amoeba-like extension, and in feathery, you have this feather-like extension, and these are typical of IGH, the well-defined margins in different configuration. And other distinctive feature is this perifollicular pigment retention, which we are seeing here. You will also see this in pybaldism and vitiligo, but again, you also see this in idiopathic guttate hypermetrosis. So this is the summary of the talk. We discussed 4 different diseases. You can see that vitiligo and IGH has a diffuse white glow, but that diffuse white glow is actually absent in nevus depigmentosus. If you see the margins of vitiligo has a smooth margin, whereas nevus depigmentosus has a very feathery or an irregular margin, and IGH has this pseudopods or feather-like extension. And leukotrichia is seen in vitiligo patches, whereas leukotrichia is generally not seen in nevus depigmentosus. With this, we come to the end of this talk. Because of paucity of time, I would not be discussing other conditions. We have summarized all these conditions in this review article with Dr. Ankad on dermoscopic features of hypo and pigmentary and hyperpigmentary conditions. It's an Indian Dermatology online journal, and the delegates can refer to this for further reading. And we have given a beautiful flow chart also for hypopigmentary conditions. First, we will have to see if there is a diffuse white glow. If it is there, it can be vitiligo, IGH, or pybaldism. Then see the margins. If it is smooth and regular, if it is well defined with characteristic pattern with areas of retained pigmentation, it's pybaldism. If not, it is IGH. Then you see if there is scaling. If the scaling is there, it is pityriasis alba or pityriasis versicolor. If there is no scaling, it can be LSA, nevus depigmentosis, and lepromatous leprosy. So in leprosy there is paucity of appendages. In nevus depigmentosis, you have feathery margin with retention of pigment network. I welcome you all for the level 2 course of dermoscopy and trichoscopy preceptorship and hands-on training, which we will be conducting in PGI Chandigarh on 30th and 31st August. We have very limited slots available, and the early bird closes on June 15th. So the interested delegates can visit our website, which is mentioned here, and look at the program which we have. This is the annual conference of the Dysi, and I welcome you all to join us for this important event. Thank you all for listening, and we can take up the questions at the end. Over to you, Samuel.
Thank you, sir. That was a very expert walkthrough, especially packed with clinical information, especially for vitiligo. Next, we look at the dermoscopy's role in inflammatory disorder, and it is my pleasure to welcome Dr. Payal Chauhan, ma'am. Ma'am is associate professor and heading the department at AIIMS Jammu. Ma'am has more than 90 publications, more than 50 presentations, and authorship of more than 14 chapters. Ma'am has been convener, and currently ma'am is the coordinator of SIG dermoscopy. Ma'am's areas of interest are dermoscopy, dermatopathology, and clinical dermatology. Over to you, ma'am.
Thank you so much, Somil, for the kind introduction. So starting with, am I audible?
Yes, ma'am.
Yes. So starting with the inflammoscopy, there are a number of disorders that come under inflammatory disorders. And I would say it is these dermoscopic findings in inflammatory disorders are a delight to one's eye. And if someone wants to start doing dermoscopy, they should definitely put their scope when they're seeing a inflammatory disorder. So the highlighted ones are the ones we'll try to see in this presentation. So starting with the first slide. There are a few structures, as the previous speakers have mentioned, that we need to see when we see findings under a dermoscope. We need to see the vessels, the scales, the follicular findings, other structures that could include lines, dots, globules, structureless areas, and if there is any specific clue that points us towards a certain diagnosis. So this is the first case, and everyone routinely encounters this. So psoriasis vulgaris has been found to have a very typical dermoscopic appearance. So what you see, the scales, which are diffuse, and they're white to gray, and under that they're uniform, dotted vessels that are present diffusely. So they're uniformly and diffusely distributed under the scales, and there is a dull red to pink background. So this, whenever you see these well-defined plaques and you put the scope and you're able to see these uniformly distributed dotted vessels, you should be fairly confident of the diagnosis of psoriasis. So this particularly helps when you're able to see these lesions on atypical site on hidden sites. So both the patients have these papules on genital area, and the first one has these dotted uniformly distributed vessels on a dull red background, and over here we see that the vessels are longitudinal hairpin shaped. So this is psoriasis and this is genital wart. So we can see that putting the scope can help us when we're having difficulty with clinical differentials in the clinic. So moving on to eczema. Eczema is another disorder where there are very particular findings that you should be able to see under the scope. One is the yellowish scales. So in psoriasis, the color of the scale is white, whereas in eczema it is more yellowish. And then the background, whereas in psoriasis it is a dull red to pink. Here you are able to see a yellow to brown background, and the vessels are focal vessels. Also, along with that, you're able to see yellow to brown serocrust, which is because of the underlying spongiosis, and also a yellow. This is the yellow clot sign here. Yellowish areas can be seen, and there is an adherent fabric sign. So that is because of the oozy nature of the eczema, that the overlying fabric of the patient tends to get adherent to it. That has been termed adherent fabric sign. So we undertook this study, and we tried to find out whether dermoscopy can help with diagnosis of palmoplantar eczema, help in differentiating palmoplantar eczema and psoriasis. And we found that in psoriasis, again, the scales are white to gray, and there is an underlying diffuse, uniformly distributed vessels, dotted vessels over a dull red background. Whereas when we here the point to note is that this is the view is different in each mode. So previous speakers have talked about different modes of doing dermoscopy. So this is the non-polarized mode, where we're able to appreciate the scales better. Whereas when we toggle to the non-polarized mode, what becomes more obvious are these vessels, which were not so prominent here. So they've become visible here in the polarized mode. Now, when we put the immersion fluid over it, so I put a jelly on it, now you see that the vessels have become all the more prominent. So that is how the appearance changes. So sometimes you're taking a scope and you're trying to see dermoscopy of a palmoplantar lesion without putting any immersion fluid. So you're just able to visualize the scales and you're not able to see the subtle differences. So this is psoriasis. And when the similar plaques, and when you put the scope, what you see is the yellowish scales. The yellowish scales are prominent here, and the background is again yellowish. So it is quite different to the background that we saw here, which was dull red to pink background, and this background here is more yellowish brown. And this is a case of subacute eczema, where again we see that these brownish globules, which represent the underlying sago grain vesicles, tapioca sago vesicles that are seen in eczema. So again, dermoscopy can help you find these subtle clues that they can be missed clinically, and they can be picked very nicely with dermoscope. Moving on to pityriasis rosea. So this is a disorder that again looks very nice under the dermoscope. What you see in an early lesion is a brown to red background, and you see focal vessels. The vessels are not diffuse, they're focally arranged, and there are scales, patchy scales. But when the lesion advances and it's late stage lesion, that is when you start appreciating the colorate of scale, and what alongside comes are the brown dots over a yellow-brown background. Then there is pityriasis lichenoides chronica. What we see here is the brown to yellow scales. Again, there is a background which is different from the psoriasis background, and it's a more yellowish brown background with few scattered, patchily distributed vessels. Again, pityriasis lichenoides chronica, there's a brown to red background, and then brown dots and patchily distributed vessels here. And in the late stages, you can see white structureless area. Again, we So this is one presentation that when we see in the clinics, we want to know, is it guttate psoriasis? Is it P. rosea? Is it pityriasis lichenoides chronica? So when we put the put the scope, we see that these white scales are visualized, and there's again a background of pinkish background with a number of diffusely arranged dotted vessels. So this is guttate psoriasis, where clinically the scaling is not prominent, but the dermoscopic appearance helps you clinch the diagnosis. So we undertook this study where we try to see the dermoscopic differentiating points of guttate psoriasis, pityriasis rosea, and pityriasis lichenoides chronica, where we found that the background of pityriasis rosea and PLC tends to be more yellowish to yellow-orange, whereas in guttate psoriasis it is dull red to pink. And the vessels in guttate psoriasis, as shown, are regular and uniformly distributed, whereas in pityriasis rosea, these vessels are dotted but in a patchy distribution. And the other things that you notice are in PLC are that the background tends to be brown, and late stages it tends to get a hyperpigmented area with brown dots and globules. Moving on to lichen planus. So lichen planus, again, a very, when a patient comes with papules and you're not able to figure out clinically, putting a scope really helps in such scenarios where you very nicely appreciate the white lines or the white streaks, which are the Wickham's stria, which is because of the underlying orthokeratosis and hypergranulosis, and this tends to vary with the stage. So early stage tends to have this violaceous hue with more prominent Wickham's stria and vessels in the periphery, but as the lesion advances, more of pigment, brown dots and brown structureless area starts appearing because of the pigment incontinence on dermal melanophages. So a patient presented with these lesions, what we see is it's a established lesion where we see the periphery has a number of white lines on a subtle violaceous background, and then the number of colors that we see brown, gray, and brown pigmented dots, and some vessels in the periphery here. So lichen planus. Dermoscope also helps us assess whether when we put the patient on treatment, is the patient responding. So when we see that the number of brown dots are appearing and the violaceous hue has subsided, then that means the treatment is working and the lesions are healing. So these brown dots and disappearance of violaceous hue can point us towards an inactive lesion. So this is to show that how putting a linkage fluid can help with the better visualization of underlying structures, because at times scales tend to mask the underlying findings. So here we can appreciate the Wickham's stria and the brown dots much more clearly compared to this image when the linkage fluid was not put. So moving on to lichen nitidus. Lichen nitidus has these white circular areas, and there is a central brown shadow and absent dermatoglyphics. So it's very well defined hyperpigmented border, hyperpigmented area with a brown zone surrounding it. Moving on to lichen sclerosis erythrophicus, this is again one disorder where the dermoscopic findings are very nicely appreciated. You see a lot of surface changes in the form of follicular plugs and white lines, which were previously called chrysalic-like structures, and white structureless areas. Then the other things that you can appreciate are the vessels. Again, here we see white structureless area and white lines and follicular plugs. The late stages can also have these here we see the telangiectasias, and we can also appreciate this peppering or the splaying of the brown dots because of the pigment incontinence. So moving on to morphia. Morphia tends to show these, again, white structureless areas which can be arranged linearly. They've been termed white fibrotic streams, and they tend to be a little less glowing compared to LSA white structureless areas. So this tends to help you differentiate the two disorders, and this is to show that the lesion is active, because you can see that the periphery, this is the center where you can see the white fibrotic beams and pigment structures in the form of brown structureless areas, but the periphery tends to show this erythema. So that means that the lesion has activity. Moving on to discoid lupus erythematosus, again very nice findings under the dermoscope. You tend to see a lot of follicular prominences, and it is said that the active lesion also tends to have follicular red dots. So active lesion will have a follicular red dot apart from the follicular plugs, and the other things that you note are the pigment dots, the brown dots, and perifollicular white halo, and the rosettes. So DLE is another disorder that has shown that white dots can be seen under the dermoscope. So as the lesion has advanced and it is more established lesion, then you see that the white structureless areas tend to become more prominent and telangiectasias tend to become more prominent, and the white perifollicular white halo has disappeared, and instead of that there is a more diffuse white structureless area along with the yellow follicular plugs. So this is the last disorder, porokeratosis. Again, very nicely seen under the dermoscope. There are this margin is very nicely appreciated. This is a double-edged marginated scale seen in porokeratosis, can be appreciated very nicely under the dermoscope, and the center can have variable findings including red dots, brown dots, which can represent the dilated vessels and dermis or the pigment incontinence. So thank you so much. And again, I would like to invite you to dermoscopy and trichoscopy workshop hands-on training, which is to be held in PGI Chandigarh in August. And there will be a wide representation of Dysi in the same. So let's, all of you who are interested in dermoscopy, please come and learn. Thank you.
Thank you, Payal ma'am, for that engaging and highly informative session. We'll be moving now. It's time for an interactive segment and the panel discussion and question and answers. We are privileged to have Yasmin ma'am as our moderator. Yasmin ma'am is currently heading the department of dermatology in Government Medical College, Srinagar. Ma'am has more than 160 publications, more than 10 international, numerous national, and authored more than 32 chapters in the books. Ma'am has received multiple awards, and ma'am has finished her fellowships in skin cancers and lasers. Ma'am's field of interest are dermoscopy, trichology, lasers, pigmentary disorders, and skin cancers. And over to you, ma'am.
Thank you, Dr. Soman. Am I audible?
Yes, ma'am.
Yes, ma'am.
Okay. So after these enriching discussions by our esteemed speakers, we'll be having a panel discussion mainly on the basics today, and all the esteemed speakers are my panelists. Because being the first webinar of the Dermatoscopic Society of India, we just want to start from the basics to make our audience, our students or postgraduates very familiar with the dermoscope. Those who are using it are already familiar. Those who have not used it as yet will be picking up. So just Dr. Ankad, I would like to hear from you quick comments that why do we need to do the dermoscopy once we know that the histopathology is a gold standard, and then there are other investigations there. So quickly tell us why you started doing scopy and now you have spread it in the whole India like this.
Okay, thank you, madam. Why to scope? Dermoscopy is non-invasive. It's rapid and it can be done multiple times, and images can be captured. And for example, a patient comes with a skin lesion. We think one particular condition, we have few different cells. Say, for example, 4 different cells. When we keep scope, it becomes 2. Sometimes it's a diagnostic. This is how I do scopy in all the lesions.
Right. So that is the most important advantage, that we can do it repeatedly and at multiple places, and then for follow-up as well. Right. And most important thing I feel is that the patients get very much satisfied once we spend time with them with the help.
Gets convinced. For example, most common example is TSDF. If you see many times, if you show the vessels, they definitely understand and get convinced that I should not use steroid.
All right. Okay, so now Dr. Priyadarshini, what is the sequence of using dermoscope in various dermatological indications? Like, how do you start? What is your favorite way of this sequence?
Ma'am,
Is
I
it-
usually ma'am, am I audible? Ma'am, I usually
yeah.
start with non-polarized contact, and then I go to the polarized contact and non-contact both. For example, as ma'am told also, Samipa ma'am, in case of pigmentary lesion, I usually prefer that polarized non-contact because the vessels will not be compressed. Then I go for that linkage fluid, and the linkage fluid non-polarized, then there is the linkage fluid polarized, because with the linkage fluid the scales get masked. So in case I prefer first the non-polarized one so that I can see the surface features, then I go to the detailed features.
Yeah, this is the thing where most of the beginners are usually confused at how should we start and move ahead. So as you rightly said, but like in some conditions where we want to see the very superficial details as well, like Komodo like openings and this, maybe we will not like to use the linkage fluid at the beginning. So we may even
Yes, ma'am.
start with the polarized non-contact and then move over to non-polarized, because obviously you have to use a gel there, you have to use the linkage fluid. So anyone has
So
any
ma'am,
more
I start
comments?
with without linkage fluid, then I go to the linkage fluid.
Yeah. All right. And as you did the first introduction, what is somebody had put the question also, what is the difference between polarized and non-polarized? I mean, we know that obviously polarized makes us much wiser by seeing the deeper, but what actually is it? I mean, why should we think so much about the polarized way of using the dermoscope?
Ma'am, actually, in case of non-polarized, what happened? We can see with the contact plate, we can see the surface things. So the light get reflected from the surface. So whatever the surface features are there, that we can see. In case of polarized one, there is a cross polarization method in which we use two filters, which is at an angle of 90 degree. So when the light passes through the first filter, then there will be the light get polarized, and the light which get reflected from the surface will be blocked by the second filter, whereas the deeper light the rays which goes to the deeper structure, that become non-polarized, so it get easily passes through the second filter, so that we can see the deeper features. Therefore, in case of non-polarized one, we can see that comedone like opening, whereas in case of polarized one, we can see the deeper features like the vessels and the pigmentary structures. So there is a cross polarization method that is used in the polarized dermoscopy.
Okay, so all those who are doing it, they should understand the value of doing mainly the polarized one. And most of the times, you should toggle between the two, non-polarized, polarized, because definitely you are going to see some features in a nice way, especially if you do the blink sign and other things. So toggling is very important. So this is how the contrast is there between non-polarized and polarized modes. So all the beginners will understand it once they go on doing. And there's a new thing, I think Dr. Payal will be telling us about this. Dr. Payal, there's another term known as a parallel polarization. So just some people who are using it, they want to know about it, what it means.
So, ma'am, like Priyadarshini ma'am mentioned that non-polarized is for superficial surface. So, Downlight 5, I think, is the dermoscope that's come up with parallel polarization. So, this mode, it helps to appreciate the very superficial structures, because the polarizer is aligned, in the dermoscope is aligned with our viewing angle. It's not at the 90-degree angle. So, it is to pick up the most superficial structures, even better than non-polarized mode.
Yeah, and the use of this gives us a full spectrum. We move from parallel polarization, then we move to the non-polarized, and we move to cross-polarized, or what we say polarized. So it gives a full spectrum of superficial, then medium depth to the deeper layers of the skin, so that we can see the full spectrum, especially in some kinds of the cancers. Okay. Now, Dr. Samipa, can you tell us, please, that we have so many accessories sometimes with the dermoscopes, and I think sometimes we don't know their uses. uh, because for the beginners it's very important to know they have certain accessories or they want to learn about new accessories. Anything you want to add in this?
Yes, ma'am. So I think the first thing that we'll talk about is the ice cap attachments that is available with the Dermlite dermoscopes. So ice cap attachment are things which can be detached from the faceplate of your dermoscopes, and you can also use it for, you can sterilize it and use it in conditions which is infectious or infective conditions, or even for the mucosal lesions, or when you want to see any lesions which is infected like a tinea capitis or things like that. Then comes in the attachments to the phones, which is available. So you have the universal attachment, then you have the magnetic ring attachment, which is attached to your phone per se, and there is a magnetic ring which is there on the universal attachment as well, and they both club together, and that's how it attaches the dermoscopes. Then you also have a faceplate attachment which comes with a wider view angle for the iliopodermoscope, which can be used for scoping a larger surface area. You have the charging cables which come attached with it. Most of them come with a case as well with the dermoscope, and then you have this silicone casing, and also sometimes the tag which you can use to just put your hands through it to hold it, or keep it around your neck area. So the most commonly, I think what I use is the faceplate, because the ice cap attachments, because they can be disconnected and you can also sterilize it and reuse it if you are not able to use the cover that the phone covers that was told by Dr. Priyadarshini Sahu. Also, I use for that interface medium, I also use a glass slide most often because it's just easy to dispose it of.
Dr. Vinay, can you add, like, we have this magnetic eyepiece and other things, like what are they usually used for? Dr. Vinay is there?
Yes, ma'am. We can use this magnetic eye field to attach it for with camera, or if you want to have a distance to visualize it. So I generally don't use it because it is an add-on. It should be bought separately.
Yeah, and then we have nowadays, like, we have this contact plate, but recently there are very small contact plates as well, which can be attached for some difficult to reach areas. So many accessories are now being provided so that we can make dermoscopy more refined and make the best use of it at those sites where it's usually difficult to use, like in genital areas, flexural areas, and other places. So this is the USB one. So Dr. Vinay, please, just a bit of elaboration about these attachments, because our viewers are usually using these types of.
Yeah. So the USP dermoscope, one of the advantages of USP dermatoscope is it gives a higher magnification. But I personally feel that the clarity of the image is much better than the handheld dermoscope versus the USP dermoscope. The other advantage of USP dermoscope it is slender, and you can actually go into the orifices very easily. So if somebody wants to do mucoscopy, then USP dermoscope is better to use than a handheld dermoscope, because handheld dermoscope are bulkier and you cannot put it with inside the oral cavity, whereas USP dermoscope can easily be put in. And also USP dermoscope is helpful when you want to mark a lesion for biopsy when you are actually doing dermoscopy. So you can actually have a port between the USB dermoscope and the skin, through which you can put your pen and then mark it. So that is where again it comes in handy. And USB dermoscope can directly be connected to the laptop. So when it is connected to the laptop, you get the images live on the laptop. So if you want to show it to the patient, discuss with them, then again it becomes handy. It might be difficult to do all this on a handheld dermoscope, where you will have to use a phone to attach and then show it. So if you have a office-based setup, then USB dermoscope might be good for you.
Yeah, and one more thing, like these attachments, they're specifically useful for this nail fold capsuloscopy, because obviously we can see very magnified images, and for trichoscopy also it's considered very good. And I'll ask Ankit sir once again that what do you feel is the best dermoscope for the beginners? I think this is the most important question which most of the beginners ask us. And not only the beginners now, because now we see that the dermoscope is with us even in India for more than 15 years. And most of the dermatologists are getting now experienced in it. So as we move ahead, what are the best dermoscopes for even the experienced ones? So Ankit sir will be the right person to answer these.
Yeah, since beginning, there is no conflict of interest. Since beginning, I'm using Dermlite. Recently, I'm using Photo Finder Handy Scope and Illuco also. Mm, and Hind Delta from Germany, I don't used. I have not used. But for beginners, Illuco, if money is less for dermoscope, if money is good enough, rich enough, so one can go for Dermlite. In between Hind Delta, it's also very good. For this is for beginners, and for experienced, the scope that is very useful is retroscope. What is meant by retroscope means so you take image and analyze it retrospectively. So then you will come to know what exactly is happening there. So
Yeah.
when I used video dermoscopes, Dynolite, it is almost 100K, more than 100K now. So it's also useful, and we have photo finder in our department. So any other thoughts from other panelists are welcome.
Yeah, because you have used Photo Finder also. That's what I actually wanted to know. That do you feel that for experience they should move to the high-end ones like Photo Finder and others? Because sometimes we feel now this is too much. We want some higher magnification and we want to do some more things.
Photo finder, I feel it's a very good instrument for hair trichology, because it comes with a trichoscale, that is a software which calculates, and it's mainly because of research purpose. And if you buy whole body mapping in photo finder, which is more costlier, almost 40 lakhs or 50 lakhs, so it can analyze atypical moles, and there are few other PASI score analysis also have come. So before and after treatment also it can analyze. Even MASI score, that is melasma, they are coming up. So there is a lot more things, but it is very costly. I think many of us may not afford. It's for research purpose.
In institutional use, it can be got. I think as we are now into the field of dermoscopy, we should try to encourage it for the institutional use. Any comments from Dr. Vinay?
Yes, ma'am. I agree with what sir has told. So it also depends on the interest or the reason why one wants to use a dermoscope. So if somebody has a predominantly trichology practice, office-based practice, then for them a USB dermoscope will be helpful. If somebody wants it for research purpose, and then photo finder is something which they can go for. And if somebody wants to use it in day-to-day practice, and if they especially have multiple clinics where they have to visit, then a handheld dermoscope, either Illuco or Dermlite, would be better. So it depends on their interest and the type of practice they have.
Okay. Dr. Priyadarshini, can you tell us about the various ways of dermoscopic photography systems? Like we know all of us use smartphones and this, so I'd like to use a better way of photographing. Any tips for the users?
Yes, ma'am. Actually, I usually use Dermlite. So whatever I'm telling now is for especially for the Dermlite. Dynolite also I use, but is only for the onychoscopy and NFC findings, to know the NFC finding. So, ma'am, in case of Dermlite, first of all, we want to focus that image. So, as I have shown in my PPT also, we need to focus the image. We have to set it at the ensure that the contact plate is extended properly. Second thing is that if you're not extending the contact plate, there will be a black issue. Sir, Ankat sir has also shown it to the videos. It is very nicely, sir has shown it. And I also use that interface, liquid interface medium, to especially for that interface medium. I use that to minimize the vessel compression, and to use it the fresh I always use it every time I use the fresh contact fluid to avoid the bubble formation. I also adjust the camera zoom and the focus and the clarity, and I usually take the multiple shot so that I can use the clearest image out of that. I try to include that measuring scale also during dermoscopy, so that I can measure the size of the lesion, and the with follow-up also it become easy, so that I can tell yes, this number, the lesion has been increased in the size. So I usually
And Dr. Somin, can you give us some important tips regarding the photography? I think you are the best person to comment on this, Dr. Somin.
Yes, ma'am. Usually, it's not a single time that you should not take one photo. So what I personally believe, you have to take numerous photos. Second is always there is a rim of out of focus that is there. So it should always be inclined perpendicularly onto the skin, like as parallel to the skin. Otherwise, if you do it at an angle, it becomes difficult. Focal length varies, as was actually covered by Priyadarshini Sahu ma'am. And one more tip is when you connect the phone, you tap on the phone to autofocus it at the right length. So once what Ankit sir also showed. So that is there. But again, it is the game is of multiple pictures. One picture will not be correct. So 3, 4, 5 pictures, and later we can always delete whichever is not done properly.
And ma'am, I usually take a photography dermoscopy picture from different areas. I start with the periphery and go to the center, so that I can see the different dermoscopy picture at different levels also, at different positions also of that lesion.
Okay. Dr. Somin, if I am exceeding the time, please let me know.
Ma'am, one thing, ma'am, actually we are getting a numerous queries about the quiz. So I just want to tell you after the panel, we will have quiz on Slido, not in the chat box.
Okay. So do we have some more time left for the panel, or?
Maybe 1 or 2 questions we can take, ma'am, and then we can.
Okay, fine. So these are the various dermoscopic photography systems, and yeah. Okay, yeah. One more thing is that, like, once we have taken the images, how do we retrieve the old images? This is one more query which most of our viewers would like to know. This I would like to ask again, Dr. Somin.
Ma'am, there are 2, 3 ways of doing it. One is what Ankit sir has told me, that he maintains a register. What I do is I have the phone all of the same company. So there is always a stamp of the photo when it was taken. And I take clinical image, dermoscopic image, and then I take the photo of the OPD card that I'm writing. So I have whole of the data together, and then I put it up in the computer maybe on the weekend. And for scoping at the same site, especially over the scalp, I have my made up landmarks which I go back to. So like there is a line that is crossing here and the line that is crossing here where it meets. So you have to make your own landmarks, especially for hair if you're doing it. And over the trunk again, if you have a clinical image in the next time you are taking from the same site from one corner or 4 corners if you take. So then it becomes easier to retrieve, like to do it at the same site. And for retrieval would be over the weekend once you transfer all the photos by the name and the diagnosis. So that usually helps.
Right. And any important softwares nowadays, or does AI have a role in helping the retrieval of these images and anything, for storing them in a proper way?
Ma'am, there was a PhotoX software by Dumlight that they used to give, and now it's little not very well done. But again, AI is there, so they automatically captures with a digital tattooing of that particular site. So especially with photo finders, they have a digital tattoo where they have taken the image, and subsequently it takes the image from, like, it shows you where the image is, and you can overlap at the same site and take the thing. And there are paid subscription for AI that is available for scanning hair, for scanning the other areas. So thus for analysis as well as for hair and other malignancy done with the help of AI.
Okay, Dr. Samipa, any special tips that if you are doing any kind of procedure while using the dermoscope?
Ma'am, so because I'm only into pediatric dermatology much, I generally use
Okay.
intraoperative dermoscopy only for majority of the times for the warts and also sometimes for the mole excisions. So what it helps in basically is to determine the margin. And what I use when I'm doing an intraoperative dermoscope is as an interface, ma'am, is generally a glass slide which has been pre-sterilized, and then I use it because it allows us to visualize the margin of clearance. Similar is with regards to the mole excisions, because sometimes when you are doing the mole excisions, you might have a margin or you might have a depth left, and it also helps us in counseling. I generally don't do any other
Uh,
intraoperative procedures much, ma'am. So these are the two situations.
Dr. Vinay will make us more wiser regarding this. He does many procedures.
Yes, so I actually use it to mark the margins of dermoscope of tumors in while doing surgery. So what I do is prior to the operation, I look at the surgical margins clinically, and I mark the surgical margins, and then I do a dermoscopy and see if the dermoscopy margin and the surgical margins which I have marked clinically are the same. Sometimes there is a spillover of the dermoscopic margin, then I would extend the surgical margins depending on the dermoscopy. This actually helps in decreasing the removal of uninvolved skin. So I've started removing basal cell carcinomas with just 2 or 3 millimeter margins with the help of dermoscope. So it comes in handy there.
Right. So
And
there are
this
so
is
many.
more so in pigmented BCC, because pigmented BCC we can see the pigment easily and we know where the tumor ends, and then from there you can take 2 or 3 millimeter surgical margins and then remove them.
So
Ma'am,
definitely dermoscopy. Yeah, please.
even in case of glomangiomas, the nail tumor gliomas, that is very useful because we can see the ramified vessels are there. So if we have removed that, then that is a complete excision of the tumor is there.
Yeah, definitely a lot of indications for intraoperative dermoscopy as well, but I think we have less time now. So I had kept many other questions, but I think in view of the quiz about to begin, I think we should cut short here. I had actually put some image of this infectious lesions. Just quickly, anyone can, Dr. Payal, you can tell us, like, for the infectious lesions, any special precautions?
Ma'am, we need to use those caps, or I tend to use a cling film first, because we don't, and infectious lesions, something like warts, we see very routinely. So we have to be careful. Otherwise, because we in infections, apart from superficial infections where non-polarized mode is required, mostly the work is done with the polarized mode, and we also want to assess the vasculature. So again, I tend to do the polarized non-contact mode. So, I mean, the range of infections that we see are very wide, from molluscum to pitrasis versicolor to tinea to scabies to granulomatous infectious disorders. So we have to see the surface findings as well as the underlying findings, structureless areas, the color of them, and the vessels that we see.
Right. So many other things can be
Now,
used.
I think I just want to add a point here. Most of the beginners generally used to clean the dermoscope using spirit. So many
Yeah,
of my residents also used to do it, and using spirit directly on the dermoscope actually spoils the polarizer. So
contact
this is
rate.
something that needs to be, yes,
Yeah.
that should not be done. So even if you are using a spirit swab to clean it, the dependent part should not be the dermoscope, because it will then go inside the polarizer and cause damage to the polarizer.
I think so that comes from because the microscope lens are usually cleaned with spirit. So they think that the dermoscope can also be cleaned with that. But 70% alcohol is what you use other than isopropyl alcohol. That's what is the recommended.
So you can actually remove the the foot plate of the dermoscope and then clean it separately rather than cleaning it when it is attached to the dermoscope.
With the
Because when you
yeah,
actually,
then it goes inside.
yeah, it goes inside and spoils the polarizer.
So there's another problem with that, sir. When you take off that the face plate, no, when you take it off, sometimes those dust particles or some very fine particles would go inside it, and they would keep appearing whenever you are trying to do dermoscopy. So that's very this thing. So it's a very subtle.
Yeah, difficult thing to remove from there.
And also don't use a cotton swab to clean it, because the cotton wisps will just stick and they will give rise to multiple artifacts. So that is something to be avoided.
Yeah, so actually there are a lot of tips from the experts, but I think we should stop. We are going to stop here, Dr. Somil. I think shall we stop here because people are keen for the quiz?
Yes, ma'am.
Okay, I'm going to
Get
stop
free
here.
registration for. I think they want to get that free registration that they're going to get with winning.
Yeah, that's a very good incentive for them. All the best to all the quiz participants. Okay, I'll stop here. Thank you, all the panelists, for your expert tips. It was really great learning from you.
That was a wonderful and enriching discussion, ma'am. Thank you for all the panelists and Yasmin, ma'am, for steering it so well. And now, to make things a bit more exciting, we move on to the quiz segment. We hope you are ready to test your dermoscopy knowledge and let the quiz begin. So, I'll share how we'll go about it. This will happen with the help of Slido. So, slide displays. Okay. 1 second. Okay. So let me share the screen. So is the screen visible? So do you see Dysi anniversary quiz webinar?
Yes.
Not the presenter. And yes, so we go ahead, and this is the prize. One winner gets the registration for the course that we've been talking for all this long. And there are, if not, there is always a chances of registering later. So I'll again tell this 2 times, 3 times how to go about it. So you just have to scan in 1 second, the QR code will come onto your screen. Please scan the QR code and put your name there and write send. Once you put the name, I see the name here. So as I can see, we have around 250 delegates. So I'll repeat this 3 or 4 times so that most of you can actually register and go ahead with the quiz. Quiz has 2 things. There is no negative marking, but what is really important is the time in which you answer. So that also have some marks that are given additionally that is counted. So again, you scan the QR code, or you can just go directly to the slido.com and type DYSI, and that is how also you can join. So as I see some 5 people that have already joined, I believe there'll be more people. So again, once we have a little good number, I'll repeat the same instructions again. So you have to scan this, then you have to put your name, and then you have to proceed, say yes. So what will happen is I'll show the question, and then there'll be a timer. A few questions have 25 seconds or 30 seconds or 40 seconds timer. And at the end of the timer after every quiz, we'll have a leaderboard, which will show who all have answered or who all have answered, and then the ranking would happen. And once we get through all the questions, the cumulative answer will reach, and that would give us the name of the winner who would be getting the free registration. So we are at 26, 27. I'll repeat it for one more time. We have few exciting questions that are available. You can always join in between as well. Scan the QR code, write your name, and then we'll proceed. So it is as simple as that. Time is the key. There is no negative marking. If you give a correct answer in 2 seconds, and if you give a correct answer in 5 seconds, the person who has given the answer correctly in 2 seconds would get more points. So I see 36 people, and everyone I think can see the people who have joined. We are roughly at 40. If maybe probably we'll reach 50 and then we'll go ahead. So I think 41. Again, scan the QR code, write Dysi, stay connected in the app. You don't have to scan it every time. In your phone, it will be showing the questions and the answers when you put it. It will show your ranking as well, at what rank you have answered, and that is there. And I think only first, second, third would be seen on the screen. We are going at 45. Once we reach 50, or maybe another 10 seconds, and then we go live. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Let me start with the quiz. So, which mode should be used in dermoscopy? Only polarized, only non-polarized, or both? It is time bound, only 15 seconds remaining. So you have to answer it within the time. Okay. Yes, most of you have got it correct. And let's see, Dr. Shubham Kumari has answered it the fastest. This is just for the first question. Second question is red globular ring pattern is characteristic of which disease? Again, you have the clinical image as well, dermoscopic image as well. Is it psoriasis? Is it seborrheic dermatitis? Is it pityriasis rubra pilaris or acute eczema? I'll wait for the time to end and only then we'll proceed. Okay, so majority of you answered it correctly. That is psoriasis. Yes, again, Dr. Ekta is heading the way. Then we have is perifollicular pigmentation is an important clue and it is not observed in vitiligo, IGH or nevus depigmentosis. Five, four, three, two, one. We have 51 participants. Yes, most of you got it right. So again, Pravesh is leading the way. Then we have is when was the Dermatoscopy Society of India founded? Sir covered it in the beginning, Ankat sir. All of you, if not heard, you can take guesses. Is it 2018, 2020, 22 or 24? So yes, most of you got it right. Again, Dr. Vinay is heading it. I believe it's not Vinay Keshamurthy, sir. Then we have is this clinical image. A checkerboard pattern is seen in which disease out of the following? So there are four differentials. That is what we see: sarcoidosis, mycosis fungoides, necrobiosis lipoidica, and granuloma and layer. This is a chocolate problem. Yes, almost very close. It's seen in mycosis fungoides. Again, Dr. Vinay is winning. To assess dermal granulomas, the ideal way would be non-polarized mode with interface fluid, non-polarized mode without interface fluid, or polarized mode with interface fluid. You have to pick up the most appropriate option of these three. Yes, we got the answer correct. Yes, because polarized mode, we can see the deeper structures. Again, Dr. Vinay is heading it. Diffuse white glow is not a dermoscopic feature of IGH, vitiligo, pyabaldism, or nevus depigmentosis. Okay. Yes, most of you got it correct. Again, Dr. Vinay is heading it. Then the ideal biopsy site for discoid lupus erythematosus should include which dermoscopic findings? White structureless areas with scales, follicular plugs with blue-gray clots, rosettes plus focal structureless area, thick and thin arborizing blood vessels. Yes, most of you got it correct. Otherwise, if you do it in white structureless area, you won't get anything. Dr. Vinay is heading it 8 on 8. Then we have is another chocolate question. To diagnose BCC, a mandatory criteria is presence of arborizing vessels, absence of pigment network, presence of maple leaf areas, and blue-gray ovoid nests. Okay, so first is the negative criteria that we have to look for is the absence of reticular network, and only after that we proceed. Again, Dr. Vinay is heading. Then we have is obliteration of follicular opening is seen in all except nevus of aorta, horis nevus, exogenous uchronosis, and melasma. This is a very easy question. Yes, correct. Most of you got it right. Again, Dr. Vinay is heading. This is the last question. What is this sign that is seen here? Is this wobble sign? Is this ink test, blink sign, or wipeout sign? Yes, it is blink sign because we see polarized and non-polarized mode simultaneously, which will lead to disappearance of these shiny white areas. So yes, it's congratulations to Mr. Dr. Vinay, who has won it, and followed by PC. And
I think we should give to the second person. I was also part of the quiz.
okay, sir. Okay, sir. Then it is.
But I think we should pass it to the third one because PC is me.
Oh,
So
bhai.
my guru is
Okay.
first, and then it's
Okay.
PC was me. So I think we need to pass it to third one.
Okay.
Oh,
Then
you should not have done it. I think Dr. Vinay doesn't want anyone to to win this to win the scholarship to this.
okay.
Difficult to miss,
So
ma'am. So I
yes,
wanted.
yes.
That's
No, the
why.
quiz was good, so I just participated.
So it
Same,
is
same
Dr.
here.
No, yeah, we were seeing also, no? But
Dr. Rebecca is the third one.
Dr. Rebecca, she won it. Please, Rebecca, approach me at this email, Dr. Somil Damat at the gmail.com. And the people who could not win the quiz, there is always an option to attend the conference. That's a wonderful conference which will have a lot of things like this. We incorporate Slido a lot. So I think we can register onto this. And thank you. I'll stop sharing my screen and I hand over the stage to Vinay sir for the vote of thanks and the closing remarks.
Yeah. Yes. Thank you, Saumil. Can I be seen and heard?
Yes, sir.
Yeah. So good evening, everyone. And Dr. Saumil actually showed all of us a brief bird view of how our conference would be. So the conference would be a very interactive event. We would be using a lot of Slidos, questions, and a dedicated time for all delegates to interact with this. So I again welcome you all to join us in our national conference at PGI Chandigarh on 30th and 31st of August. And as we draw this enriching session to a close, it is my privilege, Vice President of Dermoscopy Society of India, to propose the vote of thanks on the occasion of our first anniversary webinar. First and foremost, I extend our heartfelt gratitude to our President, Dr. Balchandra Ankad, and Dr. Saumil Khare, our Secretary, who are the mind behind this webinar and were primarily responsible for making it a success. And to our distinguished speakers, Dr. Priyadashini Sahu, Dr. Sameepa Mukherjee, Dr. Payal Chavan, and all the panelists for sharing their invaluable insights and clinical expertise. Your engaging talk and case discussion have laid a strong foundation for our mission to advance the dermoscopic education in India. A special thank to our moderator, Dr. Yasmin Bhatt, for steering the panel discussion so smoothly and making it interactive and thought-provoking. And to all the participants who joined us from across the country, thank you for your enthusiasm and active engagement. Your presence is a strong motivation for all of us to keep moving forward with more academic initiatives, which are the goals of our society. A sincere note of appreciation to our office bearers. Some of them were not able to join this webinar because of prior commitments. And again, to Dr. Saumil Khare, was the mind behind this webinar. This is just the beginning. We look forward to all of your continued support as we grow stronger as a community and contribute meaningfully to the field of dermoscopy in India and in skin of color and dermoscopy as a whole, as a subspecialty of dermatology. Thank you again for your participation. Let us all stay connected, stay inspired from each other, learn from each other, and we will be in touch with all of you. Our membership will open soon. I request all of you to become members. And with this, I come to an end of this wonderful event. Thank you all and good night.
Thank you.
Thank you, Dr. Vinay, Dr. Saumil. Thank you all for the participation.
Sir, we can have a photo, sir.
So,
This is the
Yeah, it's
first
for official
webinar. I
purpose.
think we should
Yes.
have a photo. Yeah.
Yeah.
Some Payal, we can have your daughter also.
Yeah. That's what. Yeah. Great.